Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I'm Nicola Brook and I'm the solicitor at BJC with day-to-day responsibility for managing our work on the COVID inquiry on behalf of COVID Bereaved Families for Justice UK. I'm here with my co-host Lorelei King, who is a member of the group, having very sadly lost her husband to COVID. Joining us today to discuss the hearings this week is Allison Munroe KC. Allison works in family law, public law and human rights. She regularly represents bereaved families in inquests and public inquiries and was part of the legal team for the families in both the Hillsborough inquests and the Grenfell Tower fire inquiry. Allison is our lead KC on Module 3 and represented us this week, putting questions on behalf of the bereaved to witnesses including Sir Chris Wormold, Professor Philip John Clure and Caroline Lamb. Welcome, Allison, and thank you for joining us.
Hi, lovely to be here again. Thank you.
So nice to see you again, Allison. We're so lucky to have our KC with us today. I just wonder if we talked a bit about Professor Sir Stephen Powis last week, who's the National Medical Director of the NHS England. I just wonder if we could finish off with his evidence because he had to come back. I mean, for me, one of the moments was the CATA questioning about PPE for healthcare workers and also asking him about a letter that he signed saying that COVID is not airborne. And they pressed him hard on why he signed a letter saying it was not airborne so early. I was kind of surprised that Lady Hallett, the chair, cut off that line of questioning pretty quickly. But Nicola, we talked about Powis last week. What did you make of his finishing evidence?
I think they rely so much on what they were told in the early days, but then are so slow to respond to the new evidence as it emerges and keep saying, well, there wasn't enough evidence to justify a change. I mean, all this talk about the clinical prioritization tool, he said because of the modelling, he said he was personally terrified that the NHS was going to be overwhelmed. And so they come up with this tool that allows them to say who will be treated and who won't be. So they come up with that very early on, and yet they are so slow to respond to the emerging evidence about COVID being airborne to protect their staff. So they stick with the original masks, which wasn't going to protect anyone who was working closely with COVID patients. And the evidence seemed very clear to anyone who was working on the ground, and it just feels like people who were protected and working in offices and making decisions were just not responding to that evidence.
And Allison, we weren't lucky enough to have you last week, so I'm happy for you to touch on the whole of this evidence. But what was your takeaway from him as a witness?
On a superficial level, he came over as being quite reflective in his answers, and he presented himself. You know, he had a very genial manner in the way he presented himself. But the substance of what he was saying was no different to so many of the others, as Nicola said. What I find strange about not just him, but a lot of the witnesses, particularly those with a scientific background who'd been asked about the modes of transmission and why it was that they were so wedded to droplets and not taking a precautionary approach and not understanding that, you know, there could be more. there's something more, is that there seemed to be a lack of professional curiosity as a scientist. You must surely, part and parcel of being a scientist is that you look at what you're investigating, and you don't close down other avenues of investigation. Everything is left open on the table when you're not sure, before you come to a conclusion. But they were far too quick to come to a final conclusion right at the beginning. And then that informed how they subsequently proceeded, particularly in terms of things such as masks and protection. And that's what I find difficult to accept from not just Powys, but a lot of the evidence, similar witnesses that we've heard. I don't believe, for my part, that you would not be, as a scientist, more curious just to actually explore other avenues, and why on something as important as this, a pandemic, and as a scientist, that what you say is going to inform the civil servants and the government and other clinicians in terms of guidance, which then trickles down to the hospitals, how it's implemented, and the messages, importantly, those messages that we as a public received when they're standing on those podium, with Boris Johnson in the middle and the, Whitty and whoever as his wingmen. Those messages were the only messages that we as a public were receiving, and we are, and people understandably are reliant upon that. So when you know how important a function you're going to be playing, I do not understand, and I don't buy the explanation as to why there wasn't that critical thinking from a very early stage, and why they were so wedded to the idea that this was a droplet mode of transmission as opposed to airborne. And Whitty tried to style it out slightly, hasn't he? Whitty says, oh, well, we did all know that airborne was a possibility, but it was so low, so insignificant at that point. Well, it was still there, though. It was still there, and you couldn't rule it out. So why did you? And that question hasn't been answered by any of them. Although Nicola pointed out Miss Laura Imrie, and her answers in relation to that as perhaps giving the game away. That if they said what they really should have said, then people would have known, well, of course we don't have the masks and the proper protection for staff. And if staff knew that, then they may not want to work. And so that perhaps is, Laura Imrie inadvertently being very honest. But yeah, going back to Powys, I was, you could be seduced superficially into thinking, oh, he's really understanding the question. He's giving a very long, reflective answer. But the substance was just not there in what he said.
You make a really interesting point. I hadn't thought of it before like that with the scientists, but this idea of the precautionary principle, which I hadn't known about until learning in the inquiry, comes up again and again. And all these scientists seem to have abandoned it. I agree. That was curious. We had, after Powys, we had Amanda Pritchard, and she is the Chief Executive Officer of NHS England. There's been a lot of, I think because it got a little bit of press, but there's also been a lot of feedback from the bereaved and the people I've been listening to, because I think one of the big takeaways was she said that Boris Johnson's government blocked a request to fund 10,000 hospital beds at the height of the pandemic. A lot of us asked, what about that? She asked for staffed beds, but I think we've learned through the inquiry that was going to be difficult. That I know is a lot of people's main takeaway. And Allison, what did you think of what she had to say?
She was very polished, and she had more of the politician about her than than somebody. Well, she's not from a medical background. None of them are. You've got her from their managers, and she was a very smooth manager. Again, she had superficially came over as being sort of very genial, very concerned, and sort of leaned her head when she asked, but she was very controlled. Actually, she sought to, and to a large extent she did, when CTI were questioning her. She was controlling the questions, and any pushback, she was very much keeping it under control, and allowed to keep it under control, so that she had come along with her set agenda, her set answers, and was I thought she was, the substance of what she had to say was very, very poor. But she very much was allowed to control the narrative. That's the word I'm looking for. The narrative. She controlled the narrative of her evidence. And I was not particularly surprised, because that's almost what they're paid to do, aren't they? Is to, control the narrative. And it was interesting when she spoke about going to going to hospitals and visiting hospitals and spending a whole weekend, in meetings and in rooms with politicians. It was all very interesting. But compare that with Professor Fong. When he went to visit hospitals, it's like chalk and cheese. It's completely different experience. Hers, a very sort of PR driven. I went to see a few hospitals. I was in meetings for the whole weekend. Professor Fong on the shop floor, as he calls it, actually seeing the horrors, and it can only be described as horrors, that patients and staff were collectively experiencing. And when you listen to him and then listen to somebody like Amanda Pritchard, the disconnect is extreme. It really is extreme. And yeah, I think that's my takeaway from her evidence.
You're right about, I don't think any of us will ever recover from Professor Fong's evidence, which was one of the most powerful moments in this whole inquiry so far. I agree. And I agree, it was the same talking points. One, the bereaved are sick of hearing about, which is that the health service never had to systematically limit access to treatments because they couldn't cope with it. I know you have some thoughts, Nicola.
Yes, completely agree with what Allison has said, in that there was something about Amanda Pritchard that just was very much like watching Paula Venables give evidence at the post office inquiry. She came there willing to make certain concessions that weren't particularly damaging. So she was quite open about the state of the NHS going into the pandemic, that there was very little headroom, she said, to absorb any extra capacity. And then she did make this comment about, well, we asked for 10,000 extra beds, but that nasty Treasury and the Prime Minister, they wouldn't give it to us. So she was accepting that there was an issue with the NHS. She was accepting that they asked for more. But then she said that they were able to create an extra 4,000 beds. Now, bearing in mind her job is to run it and to operationalize things, why weren't those extra 4,000 beds there earlier? Surely that's down to an efficiency, which comes directly under her remit. She also spoke about how they never got to CritCon 4 on a nationwide basis, and that there were very few individual trusts declaring CritCon 4. So they never had to systematically limit care. And she's saying that on the basis that if one hospital declares CritCon 4, they are not limiting care. They manage that by transferring patients out. And then she said, that does not mean, though, that it did not feel completely overwhelming to staff. And that just sounded so patronizing, as though she's there talking about facts based on CritCon 4 declarations, whereas staff are talking about feelings and how things must have felt. Well, I'm sorry. We know that decisions were made to limit care. We know that people who would ordinarily have been in ITU were refused access to ITU. That's not a feeling, that's a fact. And to kind of dismiss that as nothing more than a feeling, I think really spoke volumes about her entire approach to the staff workforce anyway. And this was something that was picked up when she was talking about the Nightingale hospitals. First of all, the 358 million that was spent on what she declares was a useful resource. She talks about how the plan was, they knew that certain areas of the country weren't under pressure, so they were going to move staff from there to the places that were feeling the pressure, as though staff were just pieces that could be moved around rather than people. Also, this idea that they were going to train airline staff who were furloughed and get them to look after patients in some capacity. She didn't expand on that, but yeah, just this idea that staff are robots or pieces to be moved around at the whim of the NHS, who, don't have their own families to worry about, their own caring responsibilities. That just spoke volumes to me about their attitude towards staff.
You mentioned the Nightingales there. I was really shocked to hear the numbers, the financial numbers of what it cost, and how the Birmingham, I think one of them, Birmingham, was never even used, and it cost over 50 million. The waste is astonishing.
And the lack of reflection as well. I think one of the questions that was put to her was about the discharge policy. And so we asked about that, and asked whether they looked into whether there were any adverse outcomes from that discharge policy. And she said, oh, we didn't look into that. And she explained that the group who were discharged were all medically fit. And so they are proceeding on the basis that that initial categorization was correct. So if you're not looking into whether there were any adverse outcomes, you're not going to find any. So she can confidently assert that that policy had no negative consequences because they're not looking to find out whether it did.
I'd like to move on to a witness that, I'm sorry, Chris Wormold. I cannot tell you, watching him, how my blood pressure felt like it was going up. He was the permanent secretary, or is the permanent secretary of the Department of Health and Social Care. First of all, his voice gets to me. That's a personal thing, but it's just the kind of whining superiority. It's so condescending, and the way he draws out the ends of words. Sorry, that's just me. But more than that, just his rudeness, to the point where more than once Lady Hallett the chair had to say, listen to the question. I can say this, I found him odious. And I mean, besides his voice, the moment that I laughed the most in his testimony was when he talked about how government, they were talking about PPE acquisition. And he said, oh, the government has huge checks and balances about acquisition. I wasn't in the hearing room. I would be surprised if there weren't a very large gasp at that point. Because Allison, I have to say, your questioning of him was fantastic. I really felt you pinned him down. So I'd love to hear what that experience was like.
It was good. It was a really nice experience. And Nicola had instructed me exactly what to do before I asked my questions, because he's one of those people that has the ability to talk and talk and talk, but say nothing at all. It's just noise, word salad. And he doesn't listen to questions. He's not interested in the question that people were asking him. He just wanted to speak over. He was actually very belligerent with Jack Carey and speaking over her, not listening to the question, and just steamrolling with his answers, and being very sort of pleased with himself as well, very, very smug. And he has, again, but much more so than with Pritchard, that huge disconnect between his role and what does he think his role is? Because everything is like, well, it's not really my responsibility. And he was putting it onto NHS England or everybody else apart from his department. But it was that whole disconnect between whatever he was doing at the time and the reality for people who are actually working in hospitals and driving the ambulances and the porters and the nurses and everybody else. There was, you know, a huge disconnect. But then he superficially kept on saying about, you know, I just like to praise our wonderful NHS staff. If he said that once, he said it 1,000 times. And that was disingenuous, because you're praising the wonderful staff, and yes, they were wonderful, and yet you place them in completely invidious positions, and you made their lives a living hell because they weren't provided with the correct equipment. They weren't provided with services that were fit for purpose. They weren't provided with the proper guidance or training in some instances. And worst of all, there wasn't enough of them, you know. And so I found that really disingenuous when he kept on deflecting answers and saying, well, you know, NHS staff were wonderful. The questions that we had for him, I don't know. I think because the way he had given his evidence thus far, I could tell, and you could feel the frustration in the room, and you could feel the frustration coming from CTI themselves. I thought, well, perhaps I might get away with being a little bit more, you know, more like a normal cross-examination. But I have to say, he just instantly got my back up with his answers and not listening to my questions, that I kind of almost forgot that I had set questions, and I just thought, right, me and you, we're going to be in it now. And he, you know, sort of throwaway lines about the DNA CPR, about, oh, well, it's people breaking rules, and they're not going to, you know, we can't really monitor that, because, you know, if somebody breaks a rule, they're not going to fess up to it. And it was a very glib response to such, you know, such a devastatingly important area, not just from the pandemic, because that has had a knock-on effect that now, even now, you know, when people go into hospitals, and, you know, your relative's been taken into a hospital and you're told about DNA CPR notices, people, you know, their initial reaction is not to trust what they're being told as a legacy of what happened during the pandemic. So his response was really so superficial that I just sort of instantly, he wanted to come back at him. I didn't even ask the chair, may I have a follow-up question? I just thought, I'm so annoyed and angered by your response about rule breaking, that I said to him, you know, this is much more than rule breaking. It's far more nuanced, because you've got these clinicians who were working in extreme conditions, their own mental health at its limits, not enough staff. There's issues about training and guidance. A lot of them were very junior doctors who were making these decisions. It wasn't simply rule breaking. It's, you know, it's much more nuanced than that. And for you know, probably for the first time, he actually didn't have an answer to come back and had to sort of say, oh yeah, I can see your points, I can see your points. And then it just got worse and worse, because I just kind of felt I had to just follow through with those kind of questions, because he then tried to turn it back on me and say, well, you're blaming, you know, the wonderful NHS staff for the example we were then talking about was NHS 111, which was a system that was put in place, and their guidance was telling people, don't go to A&E, you've got to phone 111. So of course, people are in huge numbers phoning 111, and the service collapses. It doesn't, you know, it doesn't answer half the calls. It doesn't do what it's supposed to do. And he's, you know, he wouldn't accept that the service failed. And he was like, oh, but I'm not going to blame our wonderful NHS staff. I can't do that. And it's like, it's not about the staff, it's about the systems. And the system's not working. You could have the most well-trained staff in the world, the most dedicated staff in the world. If you haven't got sufficient numbers, and if the systems themselves are not fit for purpose, then it's not going to work. And he doesn't, and I'm sure he understands that, and I'm sure they all know that, and they will not accept that basic and fundamental point that if the systems and the policies and the guidance isn't correct, then it doesn't matter how good the staff is. The other thing that I thought was really quite weird with him is his response to Leslie on the questions of structural discrimination and racism, because this is the NHS, they are aware of these issues and were aware of these issues pre-pandemic, because it's such a, as an organization, it has so many Black and minority employees. So this has always been an issue for them, and they recognize it. Whether or not they're doing enough about it is another question, but they recognize it. But he wouldn't even recognize it and wouldn't even use the word racism. And I found that really very, very telling. And well, Leslie dealt with him accordingly, but he was, I think, by far the worst of those witnesses. I don't think that he probably went away thinking he did a great job, but I don't think he's made any friends with anybody. And more importantly, his answers really just to me, underscored this sort of lack of willingness to come to an inquiry that's supposed to be there to shine a light on what happened. And he's given us absolutely zero assistance in that regard.
I agree. It starts to feel like some of these witnesses, it's a waste of everybody's time. I just want to, first I do have a specific question for you, but I wanted to just say, I think it was when you came at him hard. As usual, our lawyers have limited time to question witnesses, but you came at him hard about 111. And at one point you said to him, no, I asked about steps, not discussions, because he was waffling. And that was a favorite moment. I do have a specific question, because a couple of people have talked about this to me. It's he said something about we have to be able to say in Parliament something, and I think you talked to him about that. Can you tell us what that was? Because I was not 100% clear.
Was that about? Oh yes, yes, yes. That it was in relation to the DNA CPR. That there was an email arising out of a meeting that they had, and he said that they've got to be able to say this isn't happening, this did not happen, and he wants to be in a position to say to Parliament this did not happen. And I said to him, well, you never got to that position, did you? And you're still not at that position, are you? And he had to accept, well, no, they didn't, and it's like, and I wanted to explore that more, but obviously I couldn't in the time. Is what I wanted to explore with him is, what are you doing in a meeting? Ask, and your primary concern is to be able to go to Parliament or just to say it's not happening, rather than your primary concern should be it is happening. Why is it happening? What are we going to do about this? How can we stop this happening? But their whole motivation is more about covering their backs and making sure that they can say in a political context, oh, it's not happening. And that I find really quite telling from a forensic point of view. You would have thought that meeting would spend their time saying, oh my God, I've heard about it happening in this hospital or this hospital, and in this hospital, a junior doctor said this, or in this hospital, somebody put a complaint in. And there wasn't that sort of approach at all. It's all about it's not happening. Let's be able to say to Parliament it's not happening, which is
I'm looking at Nick. I'm looking at Nicola now. I think you might agree.
So much to say about this witness. Just to give our listeners a little bit more information if they haven't been able to follow the hearings. You mentioned at the start about the procurement issue. So this was in June 2019. The department was told that it needed to get aprons in. And 8 months later, they still didn't have a single apron in their stockpile. And he would not accept that was a failing. He was just saying that's how procurement works. We have to have all checks and balances in, and that's just how it goes. He he said a few times that the government chooses to run its health services with very little spare capacity, and he made it very clear that that was a choice that the government is making, and I thought that's quite interesting. So different choices could be made, but he was also careful to say, but that would cost the taxpayer more. But I think most people would prefer more taxes to go on that than tax breaks for the rich. he also talked about DNA CPRs and said that, yes, concerns were raised during the pandemic, but he also wanted everyone to know that this wasn't a new issue. It was just something that was highlighted by the pandemic and made bigger. Well, if it's not a new issue, why hasn't it been resolved? Why hasn't it been addressed at a teaching level before the doctors even get on towards? Why isn't there a greater understanding of why it's happening so that when we hit a pandemic, when you really are going to have to make crunch decisions, people aren't looking at someone with Down syndrome and saying, no ICU for you.
Mm.
The email that came out was September 2020. After the initial reports and letters get sent out warning everyone in March and April not to use blanket DNA CPRs, by September, there are more concerns being raised. And so the email refers to Chris Wormold noted, we need to be able to say publicly and in Parliament that this is not happening. And Jack Carey from CTI said this to him. Some might read this as you being more worried about being able to say it isn't happening, irrespective of whether it was or wasn't happening. It was the optics that you were worried about rather than the reality on the ground. That was the killer question, which I think everyone in that room had on the tip of their tongues. And he answered no, not at all, and started talking about the ministerial code and how honest they all have to be, which make of that what you will. But yeah, when Allison was asking him questions, he referred to it as breaking the rules. And my concern is, given the evidence we've heard later on in the week about a decision taken by a junior doctor to put a DNA CPR on someone with a learning disability, that in actual fact, it wasn't breaking the rules and it was potentially following guidance that was laid down in individual trusts. That's my concern.
Mm.
And I know it's a concern of a lot of the bereaved too. I believe, I think Allison, you might have pointed this out, it was 422 of our members have concerns that the DNA CPRs were misused.
And there's, Nicola said there's inconsistency across the country. You've got trust to trust, having, approaching the policy in a different way, different interpretations and misinterpretations. Some training, some obviously no training, because we had Professor Ball from Birmingham, Queen Elizabeth Hospital in Birmingham, and the trust giving evidence on their behalf. And he said, because obviously Birmingham had the time and resources to do this. He said that what they did is they made sure they had very, very senior doctors in place in ICU, so that when questions about teal forms and DNA CPR came up, it was being considered by very senior doctors. And then we have people like Professor Kleur, who told us that, who gave us the examples of when it happened that he knew of. The example that Nicola's just spoken about, it was a very junior doctor who was stopped by a nurse. The nurse, thank God she was there. The nurse stepped in and said, no, you can't do that, or that's wrong. So it's fine if you've got the resources and you've got the senior doctors that you can put into ICU, but many, many, many hospitals, as we know, didn't do that. And we've heard from Dr. Tilly Kamar earlier on. She was a junior doctor who was, redeployed into ICU, had no idea about working in ICU, and probably had to make those decisions with no training and no guidance and no senior doctor to help her, and perhaps no nurse to step in when she got things wrong, or she was making a misinterpreted decision. So it's about a complete lack of consistency that predates the pandemic. And I'm still waiting for the answer in terms of what have they done, and what are they going to do to rectify that?
You mentioned Dr. Kleur there, Philip Kleur. I will not I know he is from Wales. I will not attempt to pronounce the name of the university he's from for fear of getting it wrong. So I'm happy. Was unable to see his testimony, so I'm really happy to have you guys talk about that. Would you like to continue, Allison, or shall we? Or
Yeah,
Nicola, do
he
you?
was. I'll
Okay.
just say, just add this about him. I mean, that was our main topics of questions for that were allowed, but just generally his evidence. I mean, um he was perhaps better than some, although in relation to the DNA CPR point and the junior doctor, the chair then said to him, well, because he said afterwards we had this root cause analysis investigation, that looked at why the junior doctor did this. And we also looked at another example where we were getting comments I think it was in 2020, February 2020, from learning support teams that there were instances of staff issuing DNA CPR in relation to people with learning disabilities, so very vulnerable patients. And so he said, we had this huge investigation into it, and we satisfied ourselves that, everything would be done properly. And so the chair said to him, well, in relation to the junior doctor who was stopped by the nurse, what did you ask him why he did this? And Professor Clure sort of sat there and went, no, we didn't, which was astounding because that's your first question. So when we then had a break, and obviously he finished his evidence and it got to our questions. So one of the things that I said to him, can I just come back to a point that Her Ladyship made about, why, did you ask him the question why? At which point he said, well, I've had time to reflect. I'm glad you've asked me that. I've had time to reflect since this morning. And I think we did ask him why, which I thought was, what do you mean you think? Either you did or you didn't. But he did then go on to say that there were issues around training and guidance and interpretation of the guidance and messaging, which is kind of fundamental and obviously predate the pandemic. What are you doing about this? And you got the usual answer, yes, we will be making sure this doesn't happen again. How do you make sure it doesn't happen again? Because it's obviously quite it's a widespread. It's a widespread issue, and you've got to go back to basics in terms of training and retraining and issuing consistent and clear guidance in terms of how you interpret this. And it's actually a big job. So I don't know why they're sitting on it. They know it's an issue now. They know it was an issue in the pandemic. They know it was an issue pre the pandemic, and they're not doing anything about it because it's going to come back again, any future pandemic.
You're right. And I think it's kind of a theme throughout with a lot of the witnesses where they acknowledge, yes, this has to be done, but without any concrete ideas about how to
Yes.
fix it. And Nicola, can I ask you about Professor Dr. Clure?
Yeah, so just sticking with this one incident that we know of with this junior doctor. So the reasoning he actually wrote on the DNA CPR was poor quality of life. Now, when he came back to answer Allison's questions, and he had chance to think, he said his understanding was that there was an issue of communication between some of the more senior doctors, and that led to this junior doctor misinterpreting what he had been told. So he said it wasn't a case of looking at someone with a learning disability and applying a DNA CPR. It was interpreting a discussion they'd had about intensive care and escalation. What was it in that conversation or communication that could be misinterpreted as finding that someone with a learning disability would have a poor quality of life? This is what I mean about there being a much bigger conversation about whether there was guidance on the floor in individual wards, individual trusts, individual acute care wards, that if you see this, this is how you proceed. Because I don't understand how something could be misinterpreted. And it's also a concern about the values we place on people's quality of life. And if we see someone with a learning disability, there seems to be an automatic assumption that their quality of life is lesser. And that's just fundamentally wrong. But this is what isn't being addressed. And we keep hearing about reviews being carried out on the paperwork and doing surveys and having meetings, but nothing's actually changing. And as long as nothing's changing, more of these decisions are being made and lives potentially being lost.
I agree. A point that you made there really gets to me, which is him deciding about quality of life. It's also completely subjective. How does he know? And it's this kind of arrogance. I mean, I get a bit hot on this subject because my husband is, as you know, had young onset dementia. And the way often people with dementia are treated as being the living dead, having no quality of life, it is so not true. And I do not think it is for someone who does not know someone to determine their quality of life. So that aspect of it is kind of enraging. If we stick with Wales, we also, I know we wanted to talk about Judith Paget, who is the Chief Executive Officer of NHS Wales. And there were a couple I did see her testimony. There were a couple of interesting things that happened, mostly Lady Hallett kind of going for her at length. But of course, I'd like to get your views on it, Allison.
Not impressed. To put it succinctly. I found that though with many of the Welsh witnesses, there's something strange was going on in Wales, because I from the CMOs, the CNOs, right through their witnesses, there seems to be a real lack of analysis in any depth. There's no depth. That's what it is. There's no depth to their evidence and no reflection in their evidence. And I think, yeah, I think Miss Paget, unfortunately, was another example of that. And I don't know whether it'll be interesting to see what Vaughan Gethin says next week, because I remember from module 1, I got the sense that there was obviously some communications going on between England, Scotland, and Wales, and Northern Ireland just were left out of everything as, you know, sort of like the abandoned child that nobody spoke about. There was an element of communication, but with Wales, there seemed to be, at a political level, there were issues in terms of what they were told and the you know, the two-way or lack of two-way communication. And that seems to have trickled down from the political level to the CMO and the CNO and the clinical level as well, so that Wales seemed to be operating, and yes, it's a devolved nation, but they seem to be operating in a completely different way in many respects, and taking up positions that were very different. But overall, I just found with her a real lack of depth in terms of her analysis. And I just was very unimpressed by her, considering, you know, her role and her function and what she should have been and should have been able to answer. I don't know, perhaps I'm being unfair, but I don't know what you thought, Nicola. No. Sorry.
You are definitely not being unfair. Unimpressive is one word for her. She is the perfect example of people who talks about all the meetings, reviews, and everything they carried out. And I think this is where the chair got a bit impatient. Like, yes, but what are you actually doing? I mean, she actually seemed to say this as though she was proud. She said 4 weeks ago she brought together the chief executives of NHS Wales along with their senior team and her senior team to review the Module 1 report. Really? You did that 4 weeks ago? Because the report came out in July. Why is it taking you 4 months to come together and start the review process? Everyone who was mentioned in that report was supposed to respond to it within 3 months. Why is it taking 4 months to get together? So the fact that she was holding that out as something to be proud of is one thing. The other thing to comment on was the questioning of her by the Welsh COVID bereaved group. It came across to me that their questioning was being very, very tightly controlled. I don't know if that came across to others, but they wanted to ask questions about something quite distressing, so trigger warning for anyone listening. They said that photographs were taken within the Aneurin Bevan University Health Board, and some of those photographs included photographs of patients being treated and body bags. And their question was, were those photographs taken with the consent of the patient or their family members? And the answer was that there was an absolute requirement of consent. And so the Welsh COVID bereaved asked a follow-up question, but they were shut down. They wanted to know what assurances were in place about that consent and how sure she was that the consent had been properly obtained. And they were not allowed to proceed with that question. And that felt odd to me that that was being shut down, because I imagine for anyone involved in those photographs, that would have been highly distressing. And I don't imagine the Welsh bereaved were asking that question in the absence of instructions. I think it's clear that there's something that's gone on there.
I was horrified when the chair stopped that line of questioning, because, and this is sometimes why I'll speak like as a bereaved now, why we feel we're not being listened to. The issues that are important to us are often cut off or neglected, because the bereaved have nightmares about their loved ones and what's happened and how they were treated after death. And these kind of stories, to know that maybe pictures were being taken of them that they didn't know about. I cannot tell you the amount of distress that kind of testimony or hearing just that is going to cause and has caused. I agree with you. That was a horrific moment.
And then just finally on the Welsh COVID bereaved, their questioning, they asked about the recording of nosocomial deaths in Wales and how the witness could be sure that all nosocomial deaths had in fact been recorded as patient safety incidents, because if it's a nosocomial infection, that means it's happened as a consequence of the hospital and the IPC measures not being either followed or effective enough. And again, her answer was so inadequate. She said I have to rely that the system has done what it's been asked to do, and that the process has worked. Well, what reassurance is that to anyone? Absolutely zero. Very unimpressive as a witness. And I imagine for anyone in Wales, very frustrating and difficult to hear.
Yeah, moving on to another devolved nation. On the last day, we heard from witnesses from Scotland. Unfortunately, I was unable to hear the testimony, so I'm going to rely on you. I think, Nicola, you wanted to talk about Colin Mackay. I hope I've said his name right, who was a deputy medical director of the NHS for Greater Glasgow and Clyde. Have I said his name right?
I think so, yes. So he came across as quite a good witness. He was obviously running a hospital rather than being on the front line. But right at the very start of his evidence, he said that the people who come into his hospital, their life expectancy is 10 to 14 years lower than probably the staff in that hospital, because they live in one of the most deprived areas. And that was just a very stark way of starting his evidence. I think, again, one of the most frustrating things about his evidence was about whether this question that we are still arguing about is whether COVID was airborne. And his evidence on this was great. Great in terms of his realization, but not so great as to what they went through. He said it was clear on the ground that the advice about infection control was incorrect. We were advised about droplet spread when airborne seemed increasingly possible. This was flagged to him by his internal infection control team, who was seeing strange patterns of spread which were indicative of airborne transmission. Unfortunately, it did not lead to the hospital treating COVID as being airborne spread because they felt they had to follow the guidance. They tried to change the guidance, but they didn't feel they were able to deviate from it. And that then created tension in the hospital because staff are then thinking, we've got this guidance, but that doesn't tally with what we're seeing in front of us. So how can it possibly keep us safe? And it was great that he was able to share that evidence with us, but that must have been incredibly frustrating for the staff, incredibly worrying. And again, not putting the staff or the patients first.
Saw you nodding, Allison.
Yes, I mean, and he's one of the few on this whole issue of the mode of transmission. He's one of the few that has actually been bold enough and perhaps honest enough to say what he said. And you then think, well, if those people in Dr. Mackay's hospital, Professor Mackay's hospital, could see this, why weren't other scientists seeing this? Why are they finding it so difficult to admit, you got it wrong? Or perhaps you didn't get it wrong. You knew what the score was. You knew that, you couldn't have ruled out airborne transmission, but you made a deliberate choice to go down a particular route. Whatever the reasoning, this idea that we didn't know, or we couldn't have known, it was tiny, the airborne, it was a tiny aspect at that stage. He's put the lie to that. And the fact that he said it and said it so clearly, unequivocally, was really good. And I think he did come over as being a fairly, again, he had a nice manner. He had a nice manner, but he came over as being very straightforward, and wasn't sugarcoating anything. He was just saying, this is what it is, and this is what we understood. If they could understand it, why couldn't others understand it? Why did Professor Whitty have such a huge problems dealing with that issue in his evidence? I mean, I think we know what we feel about that, but I thought he was excellent in that respect. We then had Caroline Lamb, who's a directorate, big. I think she's probably one of the highest paid civil servants in the country, and her background's accountancy. And I'm not knocking accountants. They are very useful. We all have them. They're very useful. But the fact that, and she's no different to all the other people that are put in those positions, they come from a background that has absolutely nothing to do with the NHS. And she was very much, as one would expect, someone in that position. Again, sort of a lot of her answers I found were quite superficial. She came with she did it in a less controlling way than, say, Wormold or Miss Pritchard did it, but she came with her own set answers that she wanted to give. And every question, she was better at answering questions, but she would always caveat something by saying, I'll come to your answer, but can I just say, and then sort of gave a little mini speech, and that had nothing to do with the question, and then kind of answered the question. We had some questions for her on the field hospital they had up in Scotland, the Louisa Jordan Hospital. I mean, it was quite interesting what she had to say about that, because unlike England, at least in Scotland, they looked at it and thought, well, what's the point? Because we can't staff these hospitals. So we're going to repurpose it for non-critical care. But even that wasn't that useful, because ultimately it was closed quite soon thereafter. And, you know, she has raised questions. When I said to her, you know, these hospitals, weren't they just, you know, very expensive white elephants? She kind of smiled knowingly and sort of said, well, you know, there are questions about their utility and whether they were delivering, you know, what we wanted them to. And you know, looking forward, how, you know, are you going to use them again? And she sort of fudged the answer saying, well, we didn't really use it for that purpose anyway, so I can't really answer that question. But the fundamental question is, you can't have field hospitals unless you can staff them. If you can't staff them, then they become these white elephants. So it then comes back to the question of resourcing again. And unless you address those fundamentals, you're going to find yourself in the same position come the next pandemic. You know, well, I hope that you know, if there were a pandemic under the present government, they wouldn't make necessarily the same decisions, but you're going to be your hands are going to be tied if the resourcing situation isn't significantly improved, because then that very much dictates how you know, how those decisions can be implemented. So she was, you know, she was very much as we expected her to be, much of a muchness. But yeah, Professor Mackay was the surprising, for me, the surprising entity yesterday, and by far the better witness, and one of the better witnesses that we've had from the hospitals, because of course the spotlight hospitals, the whole point was to sort of, you know, they had these hospitals that they then sort of looked at in detail what was happening. I'm not sure, I don't know what you think, Lorelei and Nicola, I'm not sure how well that worked in terms of the evidence, and because of course from start with they you know, the decision of which hospital you chose, and then more importantly than that, who you chose to give evidence on behalf of the hospital very much dictated the evidence you heard. So, you know, we didn't hear from the junior doctors. We didn't hear from the nurses who were, you know, sitting in their cars crying before they went into their shifts on ICU. We didn't hear from the porters. We didn't hear from the cleaners. We didn't hear from the people on the front line, as it were, those in the trenches. We heard from the, you know, the heads of the trust, the managers, and of course their analysis of how well the hospital coped was very, very different. No one's going to come along and say, my hospital, it was a complete disaster, everything was a nightmare, nobody could cope, you know. So whilst I can see the rationale behind why they decided to look at spotlight hospitals, the execution of that decision wasn't very good because of who they called. That's how I felt anyway.
I agree with your general point, just quickly, that we're not seeing all the kinds of witnesses we need to be. When you look at Professor Fong's evidence and how powerful and useful it was, we need more eyewitnesses like that. I agree with you, Nicola.
This has long been my criticism of the Spotlight Hospital issue. When we were first told about this, I thought it would be genuinely shining a spotlight on specific hospitals, doing a deep dive into what happened there, hearing from not just the medical director, but also the doctors, the nurses on the front line, but not just them, the porters, the cleaners, the medical couriers, the outsourced staff, but not just them, more importantly, from the patients and their loved ones, so that you had a 360 review of what was happening at the hospital. So when we heard the other week from Simon Ball from Birmingham, everything worked at his hospital. They never ran out of PPE. Where people were failing fit testing, it was fine because they were able to get 1,000 hooded respirators. But all of that was heard in a vacuum. We didn't hear from anyone working on the front line who had failed a fit test. Could they corroborate what he was saying? Were there patients there who felt that everything was falling apart? Were there loved ones there who weren't getting the visitation he said he was able to relax? And so this week we've had 2 spotlight hospitals, one in Scotland and one in Wales. At least with the one in Wales, Dr. Clower spoke about how they never ran out of PPE, although they might have come close to it at the time. But they did have an internal review, and CTI was able to put some of those comments to him and say, well, if you never ran out of PPE, why are we reading about reports from staff who had to buy their own? There's clearly a problem there. And again, it was this patronizing approach of, well, staff may have felt a certain way. Staff may have felt that the PPE they had wasn't quite protective enough, so went out and bought a higher grade. Or staff may not have been able to find PPE, so it may have felt as though we ran out, whereas they just didn't know where the store cupboard was. The whole approach of facts versus feelings again. Well, I'm sorry, if you can't find a mask, as far as you're concerned, you have run out and you are not protected. That's not a feeling, that's a fact.
Time has come to ask you for highlights or lowlights. For mine, the lowlight was Chris Wormold, and mostly I think because of his Johnson-esque thing about trying to push what they considered were things that were well done, trying to push that in and saying, but we did this when it wasn't even relevant. But there was one thing he said. He was asked about a pilot for these clear masks. It's first I've heard about this pilot, and counsel asked about the outcome of that study, and he said, oh, well, there were none to buy. And this takes me back again to Professor Jones talking about the hooded things where an offer was made to the government, we will produce these for you, and they just never heard from them. So to be able to say, oh, yes, well, we just couldn't get any, it infuriates me to hear that. So for me, that was a particular low light. Allison, can I come to you for your highlight or light?
I'm going to go for a low light as well, and it's the same, the same individual pushing the agenda, as you say. Yes, that we tried our best. We had wonderful staff, and it wasn't overwhelmed, and we got through it all. And it's an insult, really. It's an insult to the staff, and it's an insult to the patients, and it's an insult to the families to say that. And I found that, well, quite offensive, really, actually, to still in this time, November 2024, to still be pushing that agenda with all that we know and all that we've seen and all that we've read. I found that quite bizarre and very much alone.
Agree 100%. Nicola.
Okay, just to counteract your lowlights, I'm going to give a highlight. Colin Mackay on the last day, and it's his recommendation. And it's along this theme of COVID being airborne and PPE. And he said, in the future, we adopt the precautionary principle from the outset and de-escalate PPE when we know more about the illness and it becomes apparent it's not required, rather than the other way. Short and simple.
Yeah, we rarely hear that kind of a thing at the inquiry, I have to say. So a big week coming up when we're recording, I would say next week. When this goes out, it will be this week. We have some important witnesses, including Matt Hancock. And I really look forward to our podcast then. Thank you so much, Allison, for taking the time to talk to us. And thank you so much for representing us in the inquiry. We really appreciate it. And as always, thank you, Nicola.
Well, thank you. It's our pleasure. Really, it really is our pleasure to do this job and to represent the families that we do. So thank you for inviting me today as well.
Thanks, everyone.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.